Thank you very much, and let me know if I'm too loud or if you cannot hear me. If I cough a little bit, I apologize. I'm well on the recovery side, so I don't believe I'm infectious. I just want to let you know I wouldn't come if I really thought I was. Superb talks. I'm so pleased to be here and to have the honor of speaking with such incredibly well-known and wonderful myeloma experts. Dr. Davies, I just have to comment, has the most soothing voice, and I really think it was equivalent to a spa treatment. I feel healed. So I have kind of an interesting, somewhat different topic that it'd be fun to go over today, but it's what is the right therapy for you as a myeloma patient? How do you determine the right therapy strategy with your physician, whether you're newly diagnosed or relapsed refractory? So this is about everybody. I am, by the way, the medical director for clinical myeloma services at the SCCA. So we're going to cover three main topics. We want to integrate the current, how do you integrate the current standard of care with new approaches to treatment? What is minimal residual disease, and is it relevant? And what do you do if your disease is relapsed? So rule number one, very, very important. Don't be afraid to talk to your oncologist, hematologist. Please ask questions, talk to us. We should make the time, we will make the time for you so that you have an understanding of what's going on. We're very used to open and direct questions, conversations with patients. I regularly have people ask me if they can record our conversation. I got used to this. We all got used to this years ago once the internet became the norm. So don't hesitate to ask us questions. It's amazing the questions that patients will bring to us. And I'll sometimes have to go, and I'm not embarrassed to say it, and go back and look things up and think about it, and I learn. So please ask questions. The discussions when we initially meet with our patients, a newly diagnosed patient, is generally at the SCCA. It's going to be 1 to 2 hours long. These are long, deeply involved conversations. We want you to know what's going on, and we'll continue to work with you to understand what's going on. And this is so you can get the best treatment. If possible, I strongly recommend this. And remember, we're talking about how do you get the best therapy for newly diagnosed or relapsed therapy patients. Either you, the patient, or a family member or friend should assume the job of becoming a myeloma expert. I think for a lot of patients, they'll say, I just don't want to do this. I just want to be the patient. That is totally fine, and I deeply respect that. But if you're lucky, a family member or friend will take on this job, and it will be tremendous benefit for you. Knowledge is power. In this situation, in cancer, there's no question about it. It's where I used to work. 10 years ago, I worked in New Mexico in a county hospital, small hospital, very poor state. The level of understanding and opportunities for education is poor there. And many patients, I became very, very used to patients saying, "Whatever you say, doc, why are you even asking me? You're the doctor." I can tell you at the SCCA, it is not like that. I rarely hear that. But it's really true. Knowledge is power. Your physician should not be the only person with input into what's happening. You are really the ultimate decision maker. And I can't repeat this enough. There are no dumb questions. And if you ask a question over and over again, it's still not dumb. Never a dumb question. This stuff is complicated, and it's not something we were educated or grew up, most of us, to have any idea what the doctor's talking about. So how do you get educated? Again, I'm talking about doing this so that you get the best treatment. There's lots of pamphlets. The internet is superb. There are meetings. There are many, many organizations like the Myeloma Crowd who want to help you, who want to make this happen. I want to give a shout out, I think it's called, to the Myeloma Fighters. That's our group here in Seattle, and they meet over in Bellevue. And in other communities, there are groups like this. If you're in a small community, start your own group. One of my patients started a group in the Tri-Cities area, but find where the groups are, and if you possibly can, go to their meetings. It's a great way to learn. Our group is myeloma patients sharing what they know, sharing their expertise, and we're all learning from each other. Physicians go to those meetings as well. Talk to other patients, ask questions. It's just to name a few of the other groups where you can get information. The International Myeloma Foundation, their website is amazing, and I highly, highly recommend their website, myeloma.org, I'm sorry. Multiple Myeloma Research Foundation, the American Cancer Society, the Leukemia and Lymphoma Society is excellent. I've done a lot of work with them, and of course the Myeloma Crowd. Get out there, look for it. There's wonderful information out there from these organizations that you can trust. So, integrating the current standard of care with new approaches. How can you find out, am I getting the standard treatment that's used around the country? But am I possibly being considered for something better than just standard treatment? And I think the talks we've heard, Dr. Davies kind of alluded to that idea that myeloma patients are not all the same. So the standard approach, just for what it's worth, is RVD or VRD, Revlimid, Velcade, and dexamethasone for newly diagnosed patients with multiple myeloma. But it all depends on who you are and many other factors about your disease. I feel very firmly, and after going to the myeloma meeting in Boston that Dr. Davies mentioned a couple of weeks ago, I came away feeling even stronger about this, that we've really got to get to know what your goals are. How aggressive do you want to be? How much do you want to fight this disease? It's not as simple as just saying we're just going to treat it with standard therapy. It really depends on the patient, how strong they are physically, emotionally, and how much they're able to fight it. The personalized therapy thing has been covered to a significant degree, although I'm going to mention just a piece of it. So if changing the title of what I had before is how can you be sure you're getting at least standard treatment, and your oncologist or hematologist will modify the treatment as needed and whenever possible to cutting edge therapy, not just standard vanilla therapy, if that's what you want. What does standard of care mean? It's a treatment that's generally accepted to be the most effective and applicable to the largest number of patients. It does vary from patient to patient, and it even varies somewhat from community to community. Not that much, but it's still the standard of care in a very small town, like in New Mexico, in a very small town in New Mexico is not going to be the same as the standard of care in Chicago or New York, because the facilities, the resources aren't the same. Standard of care may not be the best therapy. So determining what's the best therapy for you, the individual patient, requires that your physician talk to you at length, examine you, review all of your testing with current research in mind to arrive at a decision as to what's best for you. What does standard of care mean? It kind of is saying one size fits all, but yet we've already heard from Dr. Davies, and I think really everyone who's spoken today, one size does not fit all. We're all very unique. This is one approach to modifying therapy for patients that I think is worth mentioning, and this was published by Dr. Palumbo, an Italian hematologist oncologist who's been a major leader in myeloma for many decades. And he came up with this approach that he looked some simple risk factors. If you're over 75, if you're mild, moderately, or severely frail. I think we all roughly know what frail is, but you can't walk very far. You can't get up a flight of stairs. Maybe you can do your own shopping for groceries. Maybe you can't. Maybe you can care for yourself. Maybe you can't. Those are risk factors. And if you have heart problems, Dr. Davies mentioned this, lung problems, liver problems, etc. So he came up with this simple strategy of, if you have no risk factors, then you're a go-go. Use the full standard dose. You don't need to modify anything. But if you have at least one risk factor, your oncologist should be thinking very hard about perhaps reducing the dose. And he called that a moderate go. And if you have one risk factor plus some other blood issues like low blood counts, etc., he called that, as you're getting therapy, he said a slow go. Reduce the therapy even more. And that is a mistake I do see made not uncommonly in the community, where we give the standard dose to everybody, and people who are very frail don't tolerate it well. It does need to be adjusted and considered with your personal health status in mind. So your doctor needs to know and needs to incorporate into the treatment what your goals of therapy are, how much treatment are you willing to tolerate, how do you value quantity of life, quality of life, side effects, the amount of time you spend getting therapy in the hospital, in the clinic. All of that, if possible, needs to be put together into the picture. You need to get informed and stay informed. If you want to have absolute cutting edge, the very best therapy that's available in the world today, you need to be prepared for more treatment and more testing. It's just, that's the bottom line. There's no way around it. But you could benefit from that, and you should strongly consider being in a clinical trial whenever one is available, because you will generally get the highest possible quality of care in a clinical trial. So, moving on to the next topic, MRD. What the heck is it? And I hope you have some tiny insight into it at the end of my short discussion, because this is a complicated topic. First, we got to step back and say, well, what is a remission? And a remission, this is a definition I took from the National Cancer Institute website. A remission is a decrease in or disappearance of signs and symptoms of cancer. I think that may be a little bit different from what a lot of us think about in terms of a remission. You're better, but the disease isn't cured. There are many definitions that you can use for remission, so this isn't necessarily the only definition. But your signs and symptoms are better. You're better. In a partial remission, some but not all signs and symptoms of the disease have disappeared. So in myeloma, it might be your blood counts are better, but they're not normal. Your myeloma numbers are better, but they haven't gotten to normal yet. Those might be a couple of examples. Your kidneys have stopped getting sicker, but they're still injured. Partial remission. In a complete remission, all signs and symptoms of cancer have disappeared. This is true for all cancers in general, although the cancer may still be in the body. So, and in myeloma, I think as almost everyone in the room probably knows, if not everyone, even if you have a complete remission, you're not cured of this disease. So these definitions are important if we're going to talk about MRD. So it's simple, right? Well, it's not as simple as it seems. So this is the technical definition in multiple myeloma. A partial remission is when your M-spike or your free light chains decrease by half or more. It really has nothing to do with how you feel. There's not in the definition at all. It's your numbers. It's all numbers. Your M-spike's gone down by 50%. A very good partial remission is when your M-spike's gone down by 90%. As I said, a PR is not bad. A VGPR is quite a bit better. A complete remission, by definition, your M-spike's zero, your free light chains are normal, and your bone marrow has less than 5% abnormal plasma cells by bone marrow biopsy. That's good. That's pretty good. Why is that only pretty good? This is really a very dated definition. The complete remission, at least in myeloma, is really 20, 30 years old. It's out of date. It still is useful right now today, but I'm going to show you why it's out of date. So when a pathologist is looking through the microscope at your bone marrow, the eyes are not that good. You can only see roughly 5% abnormal cells when you're looking at a bone marrow. So the old definition was, well, the pathologist really can't see any abnormal cells anymore. But using our new technology, it's much more sophisticated, and we can see at a much more sensitivity. We have much more sensitivity about seeing what's left of myeloma. So complete remission is good, but it's still not ideal. A stringent complete remission, now that is where we want to get every patient, if possible, depending on the circumstances and your health and your wishes, et cetera, and so forth. An SCR is really the new goal in multiple myeloma. So it's a complete remission, but using new technology, either flow cytometry or something called next generation sequencing, which is a genetic test, we cannot detect any myeloma cells in your body. This flow cytometry, or NGS, is far more sensitive, as I'll show you, than looking through the microscope with your eyes and saying, oh, I don't see any more abnormal cells. That's just not, that's the old days. So the new goal of therapy in a perfect world is that all patients would achieve a stringent complete remission. There's lots of caveats to that, but this is for purposes of our discussion about MRD. So if you're in a stringent complete remission, we can't detect any abnormal plasma cells with flow cytometry or NGS. You are MRD negative. MRD means minimal residual disease. We can still measure some disease, just a little bit, a minimal residual. You want to be MRD negative. You don't want to be MRD positive. And that's when if you're in an SCR, you're MRD negative. So MRD relates to the amount or the number of myeloma cells or bad guys or cancer cells in your bone marrow. It's a simple concept. The fewer cancer, some parts of it are truly simple. The fewer cancer cells in your body, the better you will do. That makes sense, I think, to all of us. It's easy to understand, and it actually turns out to be pretty true, pretty darn true. But please remember, even if you're in a remission, even if you're in a stringent complete remission, you still have bad guys, cancer, myeloma cells in your body, but at a very low number, like one bad cell in a million, one bad cell in 10 million normal cells. There's still a little bit of very resistant cancer left in your bone marrow. But the less there is, the better you will do, in general. This is a really wonderful description of that. Little bit, I ask you to bear with me and pay attention to it for just a second. And so what these different lines show us is how long it will be before your disease relapses. You can see relapse line on the top. And if you look over here on this, what's called the y-axis, 10 to the 9th, that means, I don't remember, let's see, 10 to the 6th is a million, so that's 100 million. I can't remember the number for 10 to the 9th, but that's a huge amount of myeloma cells when you're diagnosed. That's where you're starting. Millions and millions and millions of myeloma cells in your body. So if you get treated, I'll find my arrow, if you get treated along this curve and we knock it down to this level, about to 10 to the 8th, well, that's okay. The disease gets better for a little while, but it comes back pretty quickly. If you get, TTP, by the way, on this slide is time to progression, the time before the disease returns. If you get more than a little bit of therapy, say you get chemotherapy, then you get a transplant, and maybe you even get a double transplant. Dr. Holmberg was talking about that, 2 transplants. Well, the amount of disease gets less and less and less. You get down to very low levels of myeloma cells. You can see we started at 10 to 9th, now we're down to 10 to the 1st. Thank you. The lower the number of cells in your bone marrow, the longer it takes before the disease comes back. And at some point in time, we will reach such a low level that will cure the disease, or we'll come up with some therapy where the disease is not able to return. But what this is showing us is that the lower the level of myeloma cells in your body, the longer it'll take before it comes back. So in 2020, we'll just go ahead and pretend we've already celebrated New Year's. Is it relevant for the average patient? And I would say it depends. Like many things, it depends. Depends on your goals of therapy. It depends on what you're being treated with and who's treating you. It depends on whether or not you're in a clinical trial. If you're in a clinical trial, especially for newly diagnosed patients, they're going to measure MRD for sure, because that's becoming a new standard in multiple myeloma, although it hasn't yet become the order of the day. But I would say that at this point in time, routine measurement of MRD is not quite ready for prime time in routine care. MRD testing is performed on a bone marrow specimen. If you're doing next generation sequencing, you can use an old specimen or a fresh specimen. For flow cytometry, generally you're going to have to use a fresh bone marrow biopsy or bone marrow aspiration. Flow cytometry is a little bit less sensitive than NGS, so it can find one cancerous cell in 100,000 normal cells, whereas NGS is more sensitive, question mark better. It can identify one cancer cell in 1 million normal cells. But there are problems with MRD testing, and that's one of the reasons it's not really ready for prime time in general. One is that flow cytometry is available all over the world, all over the developed world, but not all flow cytometry is the same. The quality of flow cytometry varies a lot from hospital to hospital, from country to country. Next generation sequencing is not available all over the world yet. It requires a sophisticated laboratory, and money is an issue with both testing. In NGS, in next generation sequencing, there are some issues with, although it's been approved by Medicare, some insurance plans can be an issue, so the price is an issue right now. So insurance approval is problematic in some situations if you're not Medicare insured. And interestingly, MRD, it's not just one test. Your MRD status, whether or not you have and are staying in that very low level of multiple myeloma cells, changes over time. If you think about it, it's not really a surprise, but it comes and it goes, and it comes and it goes. Most importantly, there's no agreement about yet around the world which test should be used, flow cytometry or NGS. We should all be doing the same testing everywhere, but we're not. So when you say I'm MRD negative and you're in New York, it should mean the same thing as if you're in London, but it doesn't, because the testing is different. And that's a major problem. So as I've said, it's really not ready for prime time. It is being used routinely in research studies. Many academic centers are starting to use it routinely. We still don't have clear guidance regarding what to do with the results, so that's a whole different can of worms. And if it is used, you're really going to need to have repeated testing. One test is not going to be enough, because we want to make sure you're remaining MRD negative and that you haven't become MRD positive. So to finish, I'm running a teeny bit late, but relapse and refractory multiple myeloma. So there's good news and there's bad news. If you're a veterinarian, bad news, your cat has to wear an eye patch. The good news, it looks awesome. Well, I have to remember what context I wanted to use this. And if you'll notice, I had to white out another word that was there. But just to finish up, so yeah, we're going to talk in this slide about the bad news, but the good news in multiple myeloma and relapse refractory myeloma is that there's been huge progress, and there will continue to be a dramatic progress in this disease, even in the relapsed scenario. So don't despair. Things are moving ahead very rapidly. So this is the normal course of multiple myeloma. Diagnosis, chemotherapy, remission or control of the disease. You feel a lot better. Time passes, disease relapses. Get more chemotherapy, and the disease is back in control. You feel good again. Repeat again. And it goes on and on. This is the story of multiple myeloma. And we all have to understand and accept that. At least for now, this is the story. But we have very good treatments and approaches to relapse disease. So don't be too discouraged when it comes back. It's unavoidable for now, in general. There are many well-tolerated and powerful drugs that we can use in the relapse setting. Velcade, Revlimid, Pomalyst, Kyprolis, Darzalex, Amplicity. Stem cell transplantation is a powerful modality when you relapse. And if you haven't had a transplant when you were initially diagnosed, I would strongly consider having a transplant when you first relapse. It is an excellent therapy for multiple myeloma. And it's an important relapse therapy. If you've already had a transplant, a second transplant can also benefit you depending on the clinical situation. So this is recommended all over the world. There are also many other drugs that are not routinely used in myeloma that you can use in the relapse setting. Things like Cytoxan, bendamustine, melphalan, cisplatin, etoposide, doxorubicin, at least 20 drugs that we can use and mix and match when we're treating people with relapse disease. So just a very short synopsis of what to do when you're relapsed. We actually do have maps, guidance for what to do. A lot of this depends on the expertise and depth of knowledge of your oncologist, but there are now standard approaches that are recommended by experts like Dr. Raj Kumar at the Mayo Clinic in Rochester about how to approach patients. If you haven't stopped failing responding to Revlimid or lenalidomide, then there's many combinations such as DRD being daratumumab and Revlimid, the little d is for Dex. He suggests that's an excellent option if you're still responding to lenalidomide. KRD, carfilzomib, Revlimid and Dex, or Kyprolis, Revlimid and Dex, Simplicity, Revlimid and Dex, Ixazomib or Ninlaro, Revlimid and Dex are alternative relapsed options. If you're not responding, so this is how we break it down because almost everyone gets lenalidomide when they start therapy for multiple myeloma. So if you are not responding to lenalidomide, then you have a different set of choices. The DPD is daratumumab or Darzalex, Pomalyst, and the little d is dexamethasone. That's preferred, and then several other options. So even though it may seem like there's no sense at all to what your oncologist is doing, there actually is rhyme and reason now, finally, to how to approach relapse disease. Note that Dr. Raj Kumar says consider a salvage transplant if you haven't had a transplant before. And consider a second transplant if the first transplant worked really well. In second and subsequent relapses, because I remember I said this thing repeats, it just keeps going. You can see he said consider using bendamustine, a drug that was on the list earlier. Panabinostat, a drug that isn't used very often, but could also add to the activity of other drugs like Velcade. Venetoclax, Dr. Davies mentioned. Now, if your oncologist isn't treating a lot of myeloma, they may not realize they may be able to get venetoclax for you if you've relapsed. It takes sophistication, and you're treating a lot of myeloma patients to be aware of this. Anthracyclines, that's the doxorubicin that I mentioned earlier. So what do you do as you get into later relapses? We still have lots of options, and there is a plan, there is some sense to all of this. But is that all there is? Just the drugs that are available, the 20 drugs you've listed, Dr. Libby, it's kind of done? No, not by a long shot. And I've been here for more than 8 years, and it was exciting the day I got here, and myeloma is far more exciting now than it was 8 years ago for me, because there's so many promising drugs and novel therapies like CAR T cells, and many other drugs I'm going to list. And these drugs, these approaches, they call CAR T cells a living drug sometimes, they're available. They're available today in research trials. You can't get them in a routine community practice. They don't have the studies. But they're available today in research trials. And they're not, these are drugs and approaches that we know work. We don't know everything about them. That's why we're doing the studies, but these are approaches that have a significant activity. So we're not just throwing drug X that we have no idea if it has any activity or not. There's so much science that goes behind these and preliminary studies that these are very promising. And there's often already data to show you how promising. So if your myeloma is not responding to standard therapy, you need to see a myeloma specialist, because a community physician is not going to be familiar with these drugs and these approaches, and they may not direct you to the research trials. Now, doing a research study may not be your bag of tea. It may not be the kind of thing you want to do. You may not be able to travel. You may not be able to afford it. It may be too much hassle. But if it does fit for you, if it is a possibility, you need to know what's out there. And the only way you're going to know out there in general is using things like the Myeloma Crowd and also consulting with a myeloma expert. So this is, I really like this. And I think in this situation, he was right. But If your myeloma is not responding to standard therapy, your oncologist has to think outside of the box. It's critical. And if your oncologist is not an expert in myeloma, they can't. They're very good docs. They're smarter than I am because they have to know 100 different cancers. I only have to deal with 3. But they just simply cannot know the breadth of this disease. So you need someone who can think out of the box and use different therapies and guide you to trials when appropriate. I'm almost finished here. I know I'm running a teeny bit over time. What are some of the most promising therapies under development? CAR T cells, bispecific antibodies or BiTEs. In some ways, it's very similar to a CAR T cell, but you can take it right off the shelf. Currently, it's in research studies. These are all in research studies, but it's off the shelf. You can repeat it. You can give these infusions over and over again. And in fact, a BiTE therapy has already been approved for a certain form of leukemia. So this principle has already been proven and approved. Belantamab mafodotin, we've had the honor to work with this drug here at the SCCA and the Hutch. This is an antibody drug conjugate. This form of therapy is also a similar form of therapy. That's a mistype here. Is a very similar form of therapy is approved for Hodgkin's lymphoma. So again, available. Hopefully, it may be approved to certain patients, only daratumumab refractory patients. It may be approved in the near future. BCL2 inhibition has already been mentioned. By the way, belantamab can be obtained for patients outside of a research study. So if your oncologist is aware of it, potentially he or she can get it, even if you're in a small community. The problem is, so many oncologists just aren't aware of these developments. That's why you need to have perhaps 2 oncologists, an expert myeloma doc, and your local doc. That's what I recommend. And then new immunomodulatory drugs, the next generation of Revlimid and Pomalyst, CC220. So I want to thank you very much for listening to me, and boy, this is a great meeting.